Welcome to OncoPharma. I'm your host, John Bazar. I am a professor of pharmacy practice at ETSU's Bill Gatton College of Pharmacy, and this episode is sponsored by Kelly C. PharmD, an oncology education company for pharmacists. Today we've got a couple, as usual, some updates to go over. I want to start with some FDA approvals. And so the first one I'll talk about, we've talked about before on this podcast. I believe this was probably ASCO genitourinary some months ago about the LightSpark 022 data, which was a study of adjuvant pembrolizumab plus or minus belzutifan or placebo. And we had an improvement in disease-free survival. That hazard ratio was 0.72 with a year of belzutifan, a year pembro versus pembro or placebo. We got the FDA approval for this last week. We are still waiting for the publication of this. We are still waiting for the publication. I would have expected to be out by now. And then the overall survival data, we're still waiting to see when that matures. They did allow, as in other adjuvant studies with pembrolizumab, they did allow the inclusion of folks with M1 disease if there was no evidence of disease. So you had metastatic renal cell carcinoma, but it had been cut out, no evidence of disease on, say, your imaging. Which seems reasonable to try to see if those folks are curable. That it is the point of adjuvant treatment. So would like to see the subgroups to see how much the benefit is driven by folks who have disease that is occult versus trying to prevent recurrence. I guess that's the case for all adjuvant treatment. So nothing new that we've necessarily learned from this approval. So I don't have a whole lot to say about it other than now it is FDA approved. We'll see how this advances, but you'll start to see this in communities now that it's FDA approved. I expect it to be incorporated into the guidelines. Not sure if it'll be by itself or if it will supplant adjuvant immune checkpoint inhibitor as standard of care in adjuvant kidney cancer. Probably not until we see the overall survival data. At least that would be the wise choice in my opinion. The other approval that I want to talk about is the approval of capivasertib with abiraterone and angiotensin deprivation therapy and prednisone. A lot of drugs for PTEN deficient androgen pathway modulation naive or sensitive prostate cancer. This is kind of a new term, at least as far as in writing, I guess. In theory, this has been here before. But these are folks with newly diagnosed prostate cancer that have it's metastatic, that haven't been on abiraterone or enzalutamide or any of these androgen pathway modulators, okay? Not excluding bicalutamide, the old generation anti-androgens. Now, this is looking at patients who are PTEN deficient. PTEN is a tumor suppressor gene that works in the PI3 kinase AKT pathway, and capivasertib is an AKT inhibitor, inhibits isoforms 1, 2, and 3 of AKT. It had a prior approval for breast cancer in combination with fulvestrant. I believe it's with fulvestrant. Now, the Kaplan-Meier curves for the breast cancer are much larger than the Kaplan-Meier curves we see for this indication. The hazard ratio, while statistically significant, is 0.81. Really not that impressive. You look at those Kaplan-Meier curves, and there's not a ton of separation. If you look at the subgroups, that seems to be the more PTEN deficiency there is in the tumor sample, the better they do. PTEN deficiency in this study was defined as more than 90% of the tumor population on histology is absent of any PTEN staining by immunohistochemistry in the sample. The folks who had 100%, so nothing to stain for PTEN on a sample, looked like they had more benefit than those who are greater than 90%. Of course, you're adding capivasertib, a PI3 kinase, AKT pathway inhibitor. You're going to end up with hyperglycemia, some rash, greater fatigue, quite a bit of diarrhea. It's a more toxic drug. It doesn't look to have, honestly, a lot of benefit. Not an approval I'm excited about. Not one I'm like, hey, we got to start doing this, sort of a thing. Looks to have, there is some benefit from the disease, clearly. But I think it's pretty modest benefit, and you have to weigh that with the toxicity cost as well as the financial cost of doing this. Would be interesting to see what this drug looks like on progression in PTEN deficient versus upfront in everybody. We're not seeing a huge separation And I can't believe I've gone this long without saying that I think the fundamental flaw, this is Capitello 281, is that 75%, 74% roughly of patients in the study had high volume disease and they weren't offered docetaxel, which would be, standard of care if you were candidates for docetaxel. They're in a clinical trial. They're meeting all the same exclusion or inclusion criteria that you would usually have for a study like CHARTED, which established the benefit of docetaxel. And if you want to see a Kaplan-Meier curve separate for radiographic progression-free survival, which was the primary endpoint in Capitello 21, look at CHARTED, spelled with 2 A's. A huge separation there. You don't need any statistical analysis chops or knowledge to see how much better docetaxel is in that population. Now, the authors say, well, we don't know in P10 deficient because it hasn't been looked at specifically. And P10 deficiency is more common in advanced disease. Maybe it's 10 to 20% of newly diagnosed early disease. Maybe about 33% of folks with newly diagnosed metastatic prostate cancer will have P10 deficiency. So it's a sizable patient population that's going to have P10 deficiency, newly diagnosed advanced prostate cancer. So a lot of people are going to end up being offered this drug, I think. It's going to cause quite a bit of toxicity, I think, and with minimal, some but minimal benefit in reducing radiographic progression, survival events, and it seems very unlikely we'd see an overall survival benefit for this. Okay. A lot of folks, listen to this pod because they're trying to learn oncology. They've found themselves in this disease state, and they're new to this specialty, just trying to deepen your understanding for any particular disease state. To help, Kelly Karlstrom, founder of Kelly C. PharmD and the ELO Collaborative, created the Learning Oncology Companion. It's a free template that provides a structured framework for learning any cancer type. So like for breast cancer, there's a section where you'd fill out ER, PR, HER2, making sure you know what those biomarkers are, and it helps you kind of conceptualize the risk factors, symptoms, biomarker staging, treatment. Is this a chemo disease state? Is it a radiation disease state? Is it chemo and radiation together? You can download the Learn Oncology Companion using the link in the show notes. Okay, let's stick with our genitourinary, little subgroup here. And let's talk about another approval that happened actually at the end of May. And this was the approval for Durvalumab, PD-L1 immune checkpoint inhibitor, in combination with BCG, Bacillus calmette-guerin, which is a live attenuated vaccine against tuberculosis. But we instill it in the bladder, and it's great for preventing localized bladder cancer recurrence that is non-muscle invasive. So Durvalumab gets an approval in combination with BCG based on Potomac, which was compared to BCG alone. Now this Potomac was published last year. I'm pretty sure we talked about it last year when it was published. We get the FDA approval now, and it was a large study, Potomac. I'm going to, in the show notes, provide a link to a wonderful kind of commentary on this from Ashish Kamath and several other pretty respected urologic oncologists. And there's a lot of, there's a small benefit here in disease-free survival in these patients. These are patients who, it's not uncommon for folks with non-muscle invasive bladder cancer. And these are high-risk non-muscle invasive bladder cancer, so it's not surprising for their disease to come back. This has been studied a couple different times. This commentary goes over the 3 studies, 2 of which are positive, 1 of which is null. One of the things that's different is there are generally accepted definitions of high-risk non-muscle invasive bladder cancer, basically high-grade disease, whether it's carcinoma in situ, papillary or TA disease, or T1 where you're invading the connective tissue. Those are all considered, if they're high grade, all considered high risk. But there are higher risk, so if you have multiple lesions, the larger the lesion, those are high risk. And one of the arguments here is that maybe adding systemic therapy with BCG should be reserved for those the highest of the higher risk. Now, unfortunately, at least in Potomac 1, we don't have a subgroup analysis that really looks at that, although we do see some suggestion that the addition of Durvalumab is more beneficial if you have a high-risk papillary disease, but we don't look at all the potential high-risk features or very high-risk features. The other caveat here is that BCG induction and maintenance is very widely accepted as the first-line treatment for non-muscle invasive bladder cancer after you do your transurethral resection of the bladder tumor. the traditional dosing is 1 vial of BCG vaccine. This is the SWOG protocol. It's weekly for 6 weeks, and then at months 3, 6, 12, 18, 24, 30, and 36, you do another, kind of interim, you do maintenance. And the maintenance is 3 weekly doses, okay? So Potomac 1, they limited the maintenance phase to 24 months. One of the other studies here just did 1 month of maintenance BCG. So you're kind of, spiting one of the best standard treatments for non-muscle invasive bladder cancer, and then trying to show benefit when you add in an immune checkpoint inhibitor. Perhaps if we just did a ton of BCG, there'd be no difference. I think that's a reasonable criticism. However, we are in an era where we do have lots of BCG shortage. And there are times when, like, urology groups will have 2 people come in on the same day, and they only have 1 vial of BCG. So instead of giving each patient 1 vial, each patient gets half a vial. That's recommended in some of the guidelines when there are BCG shortages. And so I think we're going to, now that we have the FDA approval in this space for Durvalumab, you have, these patients are usually cared for by urologists who maybe don't have the experience giving immune checkpoint inhibitors. Maybe don't have the experience knowing what to do if that TSH comes back at 12 when they come back 6 weeks later. So there is going to be maybe a slow roll of this coming out as we learn more and more the best places. We don't have overall survival benefit for this. There are additional questions about what happens to these folks when their cancer does recur. Are they now considered refractory to immune checkpoint inhibitors? Because our standard treatment now is going to include, for metastatic disease or muscle invasive bladder cancer, is going to include immune checkpoint inhibitors. So, things have moved and changed quite a bit in bladder cancer in the last 5 years, and it continues to evolve. And with what we know now, there are probably some patients who benefit from this. Who those patients are, I don't think we know yet from this. I'm not entirely convinced, and neither do the authors of this commentary, that every patient should get this, so it'll be curious how that is accepted as we go forward. The last update I have is not an FDA approval, but is the publication of Monumental 3. So this is Talquetamab Durvaluamb in relapsed refractory multiple myeloma, published in the last week in the New England Journal of Medicine. This is, it's a pretty large study, but less than 1,000 people, fewer patients than in Potomac, that Durvalumab BCG study we just talked about. And you get about 290 people that are getting either Talquetamab and Durvaluamb, call that TD, Talquetamab, Durvaluamb, and pomalidomide, DTP, and then Durvaluamab, pomalidomide, and Dex. Big D, big P, little d. Okay, so we're comparing this to an arm that's Dara Pom Dex, which is probably a reasonable comparison arm. Okay, and this is looking at folks with relapsed refractory myeloma. So unlike the Talquetamab study we talked about last week, which was in a patient population who had all received Daratumumab, in this patient population, only about 11% of folks had received a CD38 monoclonal antibody. And Talquetamab and Dara is better, right? We see that. We see the addition of POM looks like it's a little bit better. Of course, the people who designed this study are selling Talquetamab, so they don't do formal comparison of Talquetamab, Dara versus Talquetamab, Dara, and pomalidomide. But the pomalidomide addition to Dara looks like you get a little bit more bang for your buck, but also more toxicity, as is not surprising. The Kaplan-Meier curves here separate pretty drastically for both progression-free survival and overall survival, although the overall survival is not significant at this point without long enough follow-up. Two things I want to say about this study, before I get to the details. We know that Talquetamab as a BCMA targeting bispecific is very effective, causes a lot of infectious complications, hypogammaglobulinemia, you got to check their IgG levels and replace with IVIG. We know Talquetamab causes some really bad taste changes and weight loss, maybe doesn't have as much infectious complications, and we know that we have really great CAR T products targeting BCMA. So using Talquetamab as a bridge maybe preserves as much BCMA effect later on. That's kind of the thinking to this stage, okay? One of the big criticisms I have about this study is the folks who got daratumumab, pomalidomide, and dex, 40% of them got subsequent anti-myeloma treatment, and not all of them progressed. So, okay, 40% of those 40% who got treatment, only half got a bispecific or a T-cell directed therapy. 14% got an alkylating agent. 3.8% got a plant alkaloid. Like, what are they doing? Now, this is what happens with international studies because the company's trying to get the drug approved in, more countries than are in the World Cup. And so they're trying to get, they're dealing with standards of care in places that maybe are different standards of care than here in the United States where I practice or elsewhere. So that's one thing is the post, the progression therapy is pretty weak in this study. At the time this was done, we knew teclistamab was pretty good. J&J, the people doing this study, I think that's what it is, they knew teclistamab is good because it's their drug. And only 3.4% crossed over to receive talquetamab in the control arm. So I think, any overall survival comparison is going to be maybe pointless to point out. But the main thing, you never see a study say there was a new safety signal. They usually say there are no new safety signals. I don't think they say no new safety signals in this, but they say that the side effects are consistent with the known side effects of the drug. I don't agree with that. So ataxia or balance disorders reported in 14.5% of patients in the talquetamab dara pom group, and 12.4% of those in talquetamab and dara group. That's, I've heard of these kind of like movement disorders, Parkinsonism happening after CAR T, but I hadn't heard about it with talquetamab. And if you go to the phase 1 study of talquetamab, Monumental, there's no mention of ataxia, balance disorders, or anything in that publication. If you go to the website for the company, they actually say that 4.1% of people in the first studies, the first in human studies of talquetamab had balance or movement disorders. This is not an ICANS, right? The neurotoxicity rate is there, but it's somewhat low. But these were happening at a median of 292 and 326 days. This is like 9 to 12 months after treatment that you're developing this. So it is a late, although it can happen early, but it tends to happen a little bit later. The range is like from 1 month to, basically 1 month to like 100 days, okay? So this can kind of happen whenever. It's a higher rate than's reported in the label, which is about 10%. Now you can say 14.5 versus 10, that maybe that's just the same. I don't know. It might be, but it might also be a signal that maybe there's something here that we don't yet understand. And I think that we don't really understand what causes these kind of movement disorders, and gives some hesitation. We have other options, albeit some toxic options with teclistamab, which these folks would be getting anyway. Again, this is a patient population that will be increasingly less common here in the States, folks who have relapsed refractory myeloma who have not received prior CD38 target therapy. So as far as where this talquetamab dara comes into role in practice, I think is going to be maybe somewhat small. But those safety concerns are worth noting and exploring and keeping our ear to the ground to hear about more of that. So that is what I have for you this week. Thank you for listening. You can follow me on X at PharmDeepNib, and you can follow the podcast on other social media platforms at Oncofarm or at... I don't know. You can find it. Oncofarm, search for it, find it, like, subscribe, all that stuff. Anyway, thank you for listening, and remember, doses matter.